Assalamualaikum and good morning to one and all. Today we'll start with the part 4 of the general anesthetic. I am Sheikh Abu Sufyan. Welcome you to my YouTube channel Pharma Learning Forever. At the end of this e-learning session, you are able to discuss inhalation anesthetics used currently and explain pharmacology of few important intravenous anesthetics. So let's start with the first topic, that is inhaled anesthetics which are used currently in the market or which is generally used for anesthetic practice. So the first anesthetic agent which is currently used. So this currently used means it doesn't mean it is the something which is it is only used, right? There are several general anesthetics which are older in nature but still they are in use, like nitric oxide. But these are new molecules which are used in current practice. So first it is the enflurane. So if you see the structure of the enflurane, then enflurane it consists of 5 molecules of the fluorine. So 5 fluorine molecules are present and 1 molecule of chlorine is present. So again it is a halogenated general anesthetics, and you can see it is end with suffix ane. So that I have mentioned in last lecture. So these are most of the general anesthetics which are halogenated in nature. They end with the suffix ane. So enflurane, since it is the halogenated, so it is ending with the suffix ane. Okay. So the enflurane. Now we'll see what are their its characteristics and what are their disadvantages. So we'll be trying to see the different general anesthetics. We'll see what are their properties, ideal properties, what are the disadvantages, and what is the reason why newer molecules are taking the place of the older general anesthetics. Okay, so we'll see one by one. So as a pharmacist or as an investigator, so you will get broader picture that how new molecules are come into the market and on what basis they have been given the approval. Okay, so the enflurane, if you see the property, then it produces the rapid and smooth induction, as well as it help in proper maintenance of the anesthesia. So in case of anesthesia, there are two important things. First thing, it is the induction, means the induction must be rapid in nature. It should quickly produces the anesthesia. And second thing is that the patient must be maintained in third stage, that is the surgical anesthesia, for the period as long as you perform the surgery. So the drug which is given for the purpose of maintaining the third stage of anesthesia, that is called as the maintenance drug. Okay, so sometimes you are giving some other drug to induce anesthesia and another drug to induce and another drug to maintain the anesthesia. Okay, here since it produces rapid and smooth induction and also it helps in maintenance of the general anesthesia, there is no need to add much more drugs in addition to enflurane. Okay, so that is the advantage, because it produces rapid smooth induction and it also helps for maintenance of the general anesthesia. Second important thing is that the 2 to 10% of the drug of enflurane, it is metabolized in the liver. So when you know that the some amount of drug it is going to be metabolized in liver, and if you are performing the surgery which is for maybe 4 hours or 5 hours, then looking at this as an anesthetician, he must put some calculation so that he can predict how much amount of extra drug can be given for maintenance of the anesthesia, because he know that around 2 to 10% of the drugs it is going to be metabolized. So to compensate that, he will accordingly calculate amount of the drug which is extra needed, and accordingly he will be giving the dose. So before anesthesia, all calculations are properly done based on patient condition, based on the drug that you are using. Okay, and the body weight of the patient. So many factors are considered before deciding or before doing the calculation for the dose that is required for induction as well as the maintenance of the general anesthesia. Okay, so 2 to 10% it is metabolized in a liver. Third important thing is that it introduced as a replacement for the halothane. So in last lecture we have studied about the halothane. It was the first halogenated general anesthetic drug, but problem is that their induction it is not so rapid. It produces the slow induction and the slow recovery because the halothane, it is solubilized in the blood, and we know that the drug we solubilize in the blood will be taking more time for the induction and will take more time for the recovery. Since it overcomes that disadvantage of the halothane, you can introduce it as a replacement for the halothane. Okay, so this is the benefit at the initial stage about the enflurane. Next drug, it is isoflurane. So if you see the structure of the isoflurane and enflurane, there is no much difference. So here also there are 5 molecules of the fluorine and 1 molecule of the chlorine. Now what is change in this structure? If you look at, just there is change in a position of the chlorine. So the chlorine here, the position, it is present at some other position, whereas if you see in case of the isoflurane, the chlorine, it is present at upper side. Okay, so just there is change in a position of the chlorine, and due to change in position of the chlorine, now the enflurane become a isoflurane because position it is present at iso. Okay, so you call this drug as a isoflurane. So it is also one of the mostly widely employed drug. The reason is that it produces smooth and rapid induction of the general anesthesia, and very importantly, there is very little metabolism. In case of enflurane, the metabolism, it is between 0.2 to 2%, so wide range is there, whereas here in case of isoflurane, it produces metabolism up to 0.2%, so there is no much metabolism, and 0.2% metabolism, it is negligible. There is no need to calculate and add the extra dose to compensate the metabolism of this drug. Okay, so there is very little metabolism of the isoflurane, and interestingly, it potentiate muscle relaxant and uterine relaxation. And you know that the one of the ideal property of general anesthetics, that it must produce muscle relaxation. Okay, so since it potentiate effect of the muscle relaxation, and also it produces the uterine relaxation, which is very important if you are performing the surgery of the uterus. So especially in case of the delivery of the baby, you are giving the small cut and you are externally taking out that baby from the uterus. So in that case, you need the drug which can have very good relaxation of the uterus. So isoflurane could be the good drug because it produces the potentiation of the muscle relaxation as well as the uterine relaxation. Okay. Next advantage is that the cardiac that is CO, that is cardiac output, it is maintained, and arrhythmias, it is uncommon. We have seen in most of the general anesthetics, they having some effect on the cardiac output. We have seen in last lecture in case of nitric oxide, it produces little effect on the cardiovascular system as well as respiratory system. So especially when I say about cardiovascular, so in case of the nitric oxide, it produces the effect on the circulation, blood circulation. Okay, so the vascular system. But isoflurane, here the cardiac output, it is maintained nearby normal, and it does not produces the arrhythmia. Now since it can maintain the cardiac output and it does not produces the arrhythmia, so you can use the epinephrine. So epinephrine can be used with the isoflurane. Now let's understand what is use of epinephrine, although we will be studying this in detail in local anesthetic chapter. So do remember that the epinephrine, it is a vasoconstrictor. So if you give the local dose of the epinephrine, then it produces the vasoconstriction, and if vasoconstriction it is produced, then loss of blood can be easily limited. Now in surgery, what you are giving the incision. The moment you give the incision, there will be the cut to the blood vessels, and due to that cut, there will be loss of the blood. So if you want to save that loss of the blood, if you don't want there is much loss of the blood, then you can give the local injection of the epinephrine. It is going to produce vasoconstrictions. It constricts the blood vessels, and due to constriction of the blood vessel, the loss of blood can be limited. It can be controlled to the greater extent. Okay, but you know that the epinephrine, it is an adrenergic drug. You might have studied this in the that is the sympathetic system. That epinephrine, it also produces the effect on the heart. It increases the heart rate and force of contraction. Okay, so if any general anesthetics which can increases the cardiac output or it can produces the arrhythmia, if that is the case, then giving epinephrine become more risky, because the general anesthetic itself producing the increase in a cardiac output, it itself produces abnormal heart rate, and now when you give the epinephrine, it will add into the arrhythmia and the patient condition become the complicated, or it become a serious. Okay, so those general anesthetics which produces the change in heart rate, or they produces arrhythmia, if that is the case, then you will think twice as an anesthetician to give the epinephrine. But since in case of isoflurane, there is no much effect on the cardiac output, no much effect on the arrhythmia, so epinephrine can be used with the isoflurane. So that is the greater advantage of the isoflurane. Now just look at the structure of the isoflurane. Again, it consists of the 5 fluorine molecules and 1 chlorine molecules, and chlorine molecule, it is present at the iso position. Okay, now let's move on to other part of the isoflurane. What is its effect on other system? Like on the small coronary vessels, it preferentially produces the vasodilation. So on coronary blood vessel, it produces the vasodilation, and also there is no reports of hepatotoxicity and renotoxicity. So looking at the property of isoflurane, you can say the isoflurane, it is one of the ideal general anesthetics drug, because one of the important property in case of the anesthetician, it should not affect the major organ like liver, kidney and the heart. So we have seen that does not have much effect on the heart, it does not produces the hepatotoxicity, so there is no effect on the liver, and also does not produces the renotoxicity. So that is the added advantage of the isoflurane. Okay, so now we have seen the drug which are currently used. Now let's see the inhaled anesthetics which are new kids on the block. It means these are the new drugs and newly invented molecule. And do remember that the new molecule only get approval only when they are better as compared to existing drug. If they do not have any of the ideal property which is better than existing, then there is no sense in giving approval to the newer molecules. Okay, because newer molecule, obviously when it's come into the market at initial stage, they are little expensive. Unless and until their patent get expired, it is very difficult to sell those drugs at affordable price. Okay, so desflurane, it is the one of the new kids on the block. So advantage is that it is having very fast onset and offset. Now since it having very fast onset of action, and you can quickly control its dose as well, so the benefit that anesthetician get is that you can have minute to minute control of the anesthesia. Means if you want to induce the anesthesia, the moment you have given the desflurane, it will be quickly inducing the anesthesia, and moment you stop the dose of the desflurane, the patient will be quickly recovering without any residual effect, isn't it? And why it is possible? This is possible because desflurane having low solubility in the blood. So that is the advantage, because we have seen if the drug having more blood solubility, then it delay the process of induction and the recovery. So those people who are not able to recall this, please go through my first and second lecture to understand what are the different factors affecting the induction and the recovery, and factor affecting the partial pressure. So there it will be more clear. Okay, so it having the low blood solubility, so it produces very fast onset and offset. So added advantage that anesthetician get is that he can have the minute to minute control of the general anesthesia. So that is the advantage of the desflurane. Now let's see how desflurane it is differ from isoflurane. So I have told you to remember structure of the isoflurane. So isoflurane consists of the 5 molecule of the fluorine and 1 molecule of the chlorine. Now to convert isoflurane into desflurane, what simply they did, so the desflurane it is differ from isoflurane by replacing 1 chlorine with fluorine. Now 1 chlorine it is present in enflurane, it is also present in isoflurane, right? Now that single chlorine also when you replace, right? Now when you replace that single chlorine, so total number of fluorine present are 6. Now no chlorine molecule is present in the drug. So if that is the case, then that drug it is called as the desflurane. So it is the molecule with no chlorine, because you have replaced that single chlorine which was present in isoflurane with the fluorine. So now total number of fluorine present in desflurane are the 6. Okay, so number will increase from 5 to 6. So that is the structural difference between the isoflurane and the desflurane. Second important thing is that it having the minimum metabolism. So there is no need to calculate extra dose to maintain the anesthesia. Okay, but problem is that the desflurane it is little pungent. So it is, since it is a very pungent in nature, the patient may hold the breath, he may suffer from the coughing, he may suffer from the laryngeal spasm, because you know that any drug which is irritating in nature, when that drug it is going through your respiratory systems, obviously through nostril, from the larynx it will go to the lungs. Okay, so when it is going through this, and since it having very pungent nature or a very irritating nature, then the response, that is normal response shown by the body, it is the contraction of the larynx. So you call it as a laryngeal spasm. And the coughing, okay, so coughing it is also, you may see sometime if you fry something in the kitchen, and or if that the kitchen smell it's going into your nostril, it may produce the irritation and you start the coughing. So the coughing it is a natural response to the pungency and to the irritant action of the any drug or anything. Okay, so the patient may hold the breath, it may produce the coughing or the laryngeal spasm. So that is the reason it is not generally used for the induction, because in induction person is conscious and he will show all this reflex action like coughing and laryngeal spasm, and he may hold the breathing. So what you can do, instead of inducing the anesthesia with the desflurane, you can induce with other drug. Okay, but for maintenance therapy you can use the desflurane, so that you can get very fast onset or you can say very fast control over the anesthesia. Okay, so it is not used for the induction, it is used for just for the maintenance. Okay, so although it is there, but let's see what are the effect on other organ, like no change in cardiac output, tachycardia with rapid increase in concentration it is seen. But so what you are doing to avoid tachycardia or to overcome tachycardia, you don't go for rapid increase in concentration of the desflurane. Okay, so if at all you need more concentration of the desflurane, you can increase slowly by giving IV by giving some carrier along with the desflurane. So you can use the carrier gas along with the desflurane, which is the neutral in nature, so that you are not giving the very high dose rapidly. Okay, so no change in cardiac output, but it produces a tachycardia with rapid increase in a concentration, so that can be controlled, and you can give the slow increase in concentration of the desflurane. Okay, advantage is that it produces very fast recovery, obviously because it having the low solubility in the blood that we already discussed, and it produces responsive within 5 to 10 minutes. So what is meaning of this? It means after completing the surgery, once you have given the stitches, you stop the dose of the desflurane, within 5 to 10 minutes that patient will be recovering with no after effect or no residual effect. So that is the beauty of the desflurane. It produces very fast, very quick recovery. The patient become responsive within 5 to 10 minutes. Okay, so although we have seen this many drug of general anesthetic we are using, but the old is gold. So there is the Faris can call it the old is gold. So the same thing is that the nitric oxide, it is one of the oldest drug, but nitric oxide it is still widely used anesthetic drug, because it is the old. So since this is the old drug, it is available at very cheap cost. Okay, so cost is it is very less. Okay, and it having many advantage, like it having very potent analgesic effect. Since it having very potent analgesic effect, it produces the anesthesia, potent analgesia. Okay, so there is no need to add another intravenous drug to induce the analgesia. So there is no need to add inducing agent, or additional drug is not required. So many additional drugs are not required with the nitric oxide, because it having potent analgesic action, and it is used as the adjunct to supplement other inhalation anesthetic. Like we have seen just now example of the desflurane. Desflurane problem is with the induction. It produces it having the pungent smell, and it produces the laryngeal spasm and many things. Okay, so due to increase in the tachycardia, even you cannot give very high dose of the desflurane. So in that case, you can give nitric oxide as an adjunct along with the desflurane. So I have just given you one example of the desflurane. So likewise, you can use nitric oxide in combination with the many drug where to compensate their one or more at disadvantage. Okay, so this is very interesting role of inhalation anesthetics which are currently in use, and although there are many new drugs are there on the desk, but still nitric oxide it is widely used as a general anesthetics. Now, before going ahead with the second part of today's session, we'll be discussing about important side effects of most of the general anesthetics. That is called as malignant hyperthermia. So in last lecture, I have mentioned you that the malignant hyperthermia, it is actually sudden increase in a body temperature. So severe increase in a body temperature. Now let's see what exactly it is, okay, and in which case it is happening. So we'll see the short definition of the malignant hyperthermia, because when you are studying general anesthesia, and since it is quite common with most of the general anesthetic that few patients show malignant hyperthermia, which is something which is unusual and not good while doing the surgery. Okay, so malignant hyperthermia, basically it is pharmacogenetic hypermetabolic state of the skeletal muscle. Now let's try to understand what do you mean by pharmacogenetic. So do remember that if any drug, if it's showing abnormal reaction only in few patients, not in all patients. Okay, so in selected few patients, if drug showing any issue, okay, so that clearly indicate that it is due to genetic abnormality in that particular patient. So abnormal response of the drug due to the change in genetic setup, okay, in my own language I am defining this, it is called as pharmacogenetic. So the science which deal with abnormal response of the drug due to abnormal genetic setup, it is called as pharmacogenetics. Okay, so that is the pharmacogenetics. So a malignant hyperthermia, obviously it is due to the genetic change in the only in a few patients. Okay, now exactly what is happening here, it is basically hypermetabolic state of skeletal muscle. Now why there is increase in a body temperature? Now what I will give you a simple example. Now if you are running, in the running what is happening, your muscles are involved, and when muscles are involved in the process of the running, after running there will be increase in a body temperature, or if you walk there is increase in a body temperature. So this is a natural response due to the use of your muscles and due to metabolism of the muscle. Now this is happening due to the running. Now patient is not running, you have given the injection of the general anesthetics, or you have given inhalation anesthetics, right, and the patient it is suddenly showing increase in a body temperature, because their metabolic state it is automatically become more, it is called as hypermetabolic state. So without running the or any of the activity, there will be more metabolism in the skeletal muscle. So that's called as hypermetabolic state of the skeletal muscle, which contribute to the hyperthermia, that is increase in the body temperature. Okay, so malignant hyperthermia, it is pharmacogenetic hypermetabolic state of the skeletal muscle, and it is not seen in all the patients. So it is only seen in the susceptible individual who having the abnormal genetic makeup, and only in those patients the general anesthetics produces, or it produces abnormal response in terms of malignant hyperthermia. So it is not common with every patient, it is only seen in case of the susceptible individual. So sometimes you will come to know when you are giving the anesthesia that this patient having this problem and it produces the hyperthermia. So you need to have the provision, especially in case of the ICU, so that you can easily control the body temperature. Now once you know that the patient to certain drug produce malignant hyperthermia, then you can report that in his report case. Okay, so when he is going through the surgery for next time, then a surgeon must know that last time when he undergo the surgery, he was suffer from malignant hyperthermia with particular drug. So he can avoid that general anesthetics, or he will not select that general anesthetics to induce the anesthesia. Okay, so that is very important thing while taking the decision about which general anesthetics it is to be selected, and it's depend upon number of factor. and based on that, the general anesthetic that is well suited for one person, it is not needed that that will be well suited for another person. Okay, so the drug which is well suited for person A may not be well suited for person B. So based on n number of factors, their cardiac health, their blood circulation, whether the patient is diabetic, whether the patient is hypertensive, whether the patient it is the obese. Okay, so based on disease also, and based on many factors which is related to the drug, allergy, side effect, as an anesthesia, you can select the appropriate drug for the appropriate patient. Okay, so this is about the side effect. So before going ahead with the second part of today's session, let's have quick question and answer session. So my first question is, which new anesthetic agent is used as a replacement for halothane? So we have seen this. So one of the anesthetic agent which has been used as a replacement of the halothane. Come on. So I'm going to the chat box. So let's see who give the first answer. Very good. I can see Sadia and many students, they have given the right answer, that is the enflurane. So enflurane, it is the drug which can be used as a replacement of the halothane, because we have seen there are many problems with the halothane having solubility in the blood and delay induction and the recovery. So to overcompensate that, enflurane, it is the drug which produces the quick induction and the recovery. So you can use the enflurane to replace the isoflurane. Okay, so that is the advantage of the enflurane. Likewise, even nowadays enflurane, it is replaced with other drug as well. Let's see the second question. How desflurane is different from isoflurane? What is the difference between desflurane and isoflurane? So I want to know the difference with reference to their structure. Okay, the structural difference between desflurane and isoflurane. What changes we have done to convert it into the desflurane? Wonderful. So I can see the Sadia has given the first answer. So good, Sadia. She mentioned that the replacement of the chlorine with the fluorine. Sahir also given the answer. Namira, Kajal mentioned about the 6-fluorine. Very interesting. So obviously we have seen in isoflurane, the chlorine is present and 5 fluorine group are present. In the desflurane, you have replaced this single chlorine. So now total fluorine presents are the 6. So 6 fluorine and 1 oxygen molecule. Okay, so you can define it as the 6FO as the structure of the desflurane. So very simply you have replaced the chlorine by the fluorine in case of the desflurane. My last question, very simple, that is, what is malignant hyperthermia? So I am expecting the answer in terms of two important things that we have discussed today. What is malignant hyperthermia? So today I am seeing there is little slow response in giving the answer. You should be very quick and answer should be come in the chat box, in the comment box like the flood. Okay, so it should be, my comment box must be flooded quickly with the answer. Yes, what is malignant hyperthermia? So just now we have seen that. Okay, Ruma mentioned about it is increase in body temperature. Obviously, it is hyperthermia means increase in a body temperature. But more specific answer it is given by the Namira. It is pharmacogenetic hypermetabolic state of the skeletal muscle. Okay, so two terms here. One, it is pharmacogenetics. It is pharmacogenetic in nature. It means the problem which is seen in case of hyperthermia, it is pharmacogenetic. Second thing is that it is hypermetabolic state of the skeletal muscle, and due to more metabolism of the skeletal muscle, there is increase in the body temperature. So sudden increase in the body temperature, and it is not happen in all the patient, it is only seen in case of the susceptible patient, and that is the reason why it is called as the pharmacogenetic, because it is not seen in the all the patient, only few patient it show this who having something different genetic makeup. Okay, so I have done with the question and answer part. Let's move on to the second part of today's session. So second part, it is about the intravenous anesthetics. So till now whatever we have studied was the inhalation anesthetics, and do remember that inhalation anesthetics are very important in the process of the general anesthesia, because simply by giving drug to intravenous anesthesia you cannot able to maintain anesthesia for the longer time. So the basic thing, the better option, it is giving the anesthesia which are volatile in nature, so that recovery become very fast. But still there is need of use of intravenous anesthetics agent. Now let's see first what do you mean by intravenous anesthetics, or which drug can be called as intravenous general anesthetics. Now we know that we have seen in case of sedative and hypnotics chapter, increase in grade of, there are increase in grade of CNS depression. So the lowest grade it is the sedation, then patients suffer from hypnosis. So those drugs are called as sedative and hypnotics. Okay, and the next grade it is the loss of consciousness, right? So you want loss of consciousness to produce the anesthesia. So that is the third stage of CNS depression. So if you look at pharmacology of sedative and hypnotics chapter, they also produces the depression of the CNS. Now, if same drug like barbiturate or the benzodiazepine, if you can use that with increase in a dose, if you can use their more dose, then those drug instead of producing sedative and hypnosis, it may also produces the general anesthesia. Okay, but all drugs are not called as the intravenous anesthetics. Only those drugs which having very quick action. Now look at this definition of one arm brain circulation time. So the drug on IV injection which produces the loss of consciousness in one arm brain circulation time, that is 11 seconds, are called as intravenous anesthetics. So those barbiturate or those CNS depression drug which having ability to induce loss of consciousness within one arm brain circulation time, that is 11 seconds, are called as intravenous anesthetics. Now let's try to understand what is one arm brain circulation time. When you are giving intravenous anesthetics, mostly you are giving injection in your arm. So you are giving injection into your arm and you are expecting that through arm drug should go and to the brain and it produces the anesthesia. Now the moment you inject, and if within 11 seconds if drug can reach to the brain, it can quickly produces the anesthesia. So that is called as the one arm brain circulation time. So only those intravenous general anesthetics or only those intravenous CNS depression drugs which can able to produce loss of consciousness within one arm brain circulation time, that is 11 seconds, are considered as intravenous anesthetics. Otherwise they are not fitting into the category of intravenous anesthetics. Although there are many drugs which doesn't fit into this category, they doesn't induces anesthesia within 11 seconds, but still they are used as an inducing agent for different purposes. Okay, so this is the definition of the intravenous anesthetics. Let's see why we are using it. We are using it for the induction purpose, because many drug we have seen, like we have seen the drug, very beautiful drug like desflurane, which having very good properties, but still it produces the pungency, and due to pungency produces many problems with the patient. Likewise, in case of nitric oxide, we have seen nitric oxide, it is very good general anesthetic drug, but it produces delay in the induction. So what you can do, you can add one IV drug along with the nitric oxide, so that induction can be quicker and pleasant in nature. So for many purpose you are using intravenous anesthetics. So basic purpose it is used for induction of the general anesthesia with the drug which having the slow induction, or it produces the slow induction of the general anesthetic action. Okay, so it is used for the induction, and you can maintain anesthesia by inhalation agent, because IV drugs are very dangerous, because once drug goes into the blood, so IV, what you are doing, you are directly giving injection into the blood. Now if that drug, if it is not volatile, if it is more soluble in the blood, then through blood it may reach out to the many organs. But inhalation anesthetic, what you are doing, although it is going into the blood, but you are using the drug which are having the very less solubility in the blood, so they are very volatile in nature. So they produces action in the brain specifically, and the moment you stop the drug, there will be the recovery of the patient. But so that is the reason you cannot use only an intravenous anesthetic agent, because intravenous anesthetic agent, you are exposing drug into directly into the blood circulation. So here you can use intravenous anesthetic agent for induction, and once anesthesia it is induced at lower dose of the intravenous anesthetics, now that anesthesia can be easily maintained by inhalation agent. Okay, so this is generally done and widely used practice to induce the anesthesia. Next important thing is that if you use inducing agent, if you have used intravenous agent, then it help you to reduce amount of maintenance anesthetics. Now your goal as an anesthetician is that you have to expose as less drug as possible to the patient. Okay, so even physician, he must keep goal that you are prescribing as least drug to the patient as far as possible. You are prescribing very less number of drug to the patient, because exposure of the drug to the body has one or another impact. Sometimes it is not measurable. Okay, so if you are using intravenous anesthetic agent along with inhalation anesthetics, then they help you to reduce amount of maintenance anesthetics. So dose of maintenance anesthetics can be easily reduced with the help of intravenous anesthetic agent. So that is advantage. Second important thing is that it's supplemented with analgesic and muscle relaxant action. Some of the intravenous agent, they also produces the analgesia. Okay, and they also produces the muscle relaxation. So that is the added advantage, and that is needed for doing the surgery. So suppose if we are seeing in case of some of the general anesthetic drug which does not produces the analgesia, so in their case you can give the morphine as an intravenous drug. So if you give the morphine it is the potent analgesic, like you can give the fentanyl. So that is also one of the, in classification we have seen the fentanyl, it is one of the intravenous anesthetic drug. Okay, so it is supplemented with the analgesic and the muscle relaxant in order to have the good surgery, and in order to have the pleasant anesthesia where a surgeon can give nice incision without any movement of the patient. Let's see what is the mechanism action, how it's work. So the most exert their action through potentiation of the GABA A receptor. So every time we have seen in case of even sedative and hypnotics, in case of alcohol chapter, there is a role of the GABA receptor. So now GABA receptor, what it is doing, just quickly write in the chat box. Is it inhibitory neurotransmitter or it is excitatory neurotransmitter? I am waiting for your answer. The GABA, it is inhibitory neurotransmitter or it is excitatory neurotransmitter? So let's see who give the answer, because we have studied this drug many times. Okay, very nice. I can see the answer. It is coming in the comment box. It is inhibitory neurotransmitter. Nice to see your answer in the comment box. So the GABA, it is the inhibitory neurotransmitter. What it does, it potentiates the GABA A receptor. So potentiation of the GABA A receptor, it will potentiate inhibitory action of the GABA, because GABA, it is inhibitory in nature. Since it is inhibitory in nature, the potentiation of their inhibitory action will lead to the more inhibition of the CNS. Okay, and that is what you expect, because the higher grade of the CNS inhibition produces loss of consciousness in the patient. So action, it is very simple. It potentiates GABA A receptor. So we'll see just one drug in today's session, and then we'll stop. Okay. So the intravenous anesthetic agent which are largely used are belong to category of the barbiturate, and we have seen the barbiturate in sedative and hypnotics chapter. What they are doing, they open the chlorine channel, produces hyperpolarization, and hyperpolarization, it is responsible for inhibition of the central nervous system. These are the ideal intravenous drug. Why ideal? Because they having a rapid onset of action. And second important thing is that they are ultra short acting. So in barbiturate there are different category. All category you are not using. You are using the drug which having the ultra short acting nature. It means the moment anesthesia is induced, once anesthesia is induced, their action is over. Now they should not produce other action on other organs and system. So generally, ideally, you are using those barbiturate which are rapid, having the rapid onset of action, and those which are ultra short acting in nature. So such example, it is thiopental. So let's study some plus and minuses of the thiopental and how you can manage it, and still you are using thiopental as one of the intravenous anesthetics. So as a pharmacist, you must know, because designing of formulation of thiopental, it is also based on this information. So let's see that. So if you look at their nature of thiopental, then thiopental, it is highly soluble in the water. And when you add thiopental in the water, because for IV injection you cannot give that in the solid form, you need the water soluble drug. Even you cannot give the suspension. IV injection should be given only in the solution form in order to avoid irritation in the blood vessels. Okay, so the ideal thing is that thiopental, it is highly soluble in water, but it yield very alkaline solution. Now if any drug which can produces the alkaline solution, that drug, it is not stable for a longer period of time. Now if pharmaceutical company, if that can, they can make add that drug in the water, and if they keep it as in a solution form, then it is not going to be stable. So what you are doing to avoid that, you are giving the thiopental in the powder form, and separately you are giving the water, right? And that water for injection can be mixed with the powder, and it can be freshly prepared before the injection. Okay, so it can be mixed, it can be freshly prepared before the injection to avoid the destability due to the alkaline pH which is happen after giving the injection. So the immediately after adding it into the water, immediately you can give injection, so that it should not produce degradation of the thiopental. So this is one of the important thing that you must remember as a pharmacist. Why thiopental, it is not formulated in the solution form? Why separately you are giving the powder and the water? So this is the reason. Okay, second important thing is that extravasation of the solution, it may lead to intense pain. Sometimes it produces the necrosis, that is the death of the tissue where it has been inserted, and it may also lead to the gangrene. So that is very difficult condition, that is very severe case, like it may also lead to gangrene. So what precaution you have to take as an anesthetician? You have to see that as an anesthetician you are giving exactly injection into your blood vessel. It should not go out of blood vessel. If you are going out of blood vessel and if you go into the tissue, then in those particular tissue going to produce intense pain, necrosis, and the gangrene. So this precaution has to be taken, because and you have to be very cautious while giving injection of the thiopental. Next thing is that it produces unconsciousness within 15 to 20 seconds. So although we define intravenous drug as those which can produces consciousness within 11 seconds, but it produces unconsciousness within 15 to 20 seconds. But still it is not a bad drug. There is no much delay. So within 15 to 20 seconds, it is also the good time or the quick time to induce the anesthesia. So it produces unconsciousness within 15 to 20 minutes, and it is highly lipid solubility. It having highly lipid solubility. Since it having highly lipid solubility, it can quickly reach to the brain. So that is the reason why the action it is quick. Okay, it can easily cross the blood-brain barrier. So the moment you give the injection into a blood circulation, it can cross its blood-brain barrier and can reach to the CNS to produce their inhibition. Okay, so it is highly lipid soluble. So the enter brain almost instantaneously. So almost immediately enter the brain, and it produces the general anesthesia. Let's see about the disposal of this drug, how it is undergoing the process of metabolism. So disposal, it is occur mainly by the hepatic metabolism, and elimination, it takes 7 to 72 hours. Now if you look at this T half, then there is the problem and you need to take the special precaution. What it indicate? It indicate that the drug remains in the body for more time. So as it is remains in the body for more time, it may produces residual CNS depression. It may persist for more than 12 hours. Now, if you do surgery, the ideal anesthetic agent it is one which can produce the quick recovery of the patient. Since it remains in the body for 7 to 72 hours, at least for 12 hours, it produces residual CNS depression. And so it is persists. It means the patient is not going to quickly recover. He remains in either the hypnotic form or his CNS it remains depressed. Okay, he is sedated till 12 hours. So when you perform surgery by using thiopental, you should take precaution. Although it is minor surgery, the precaution must be taken is the patient should not be allowed to leave the hospital before the time. So at least for 12 hours, although it is minor surgery for which you have given the thiopental, you should not allow that patient to leave the hospital because it produces residual CNS depression. Why it produces residual CNS depression? Because it having very long T-half between 77 to 72 hours. So these are the features of the thiopental. Let's see the disadvantages. It is a poor analgesic. So opioids or nitric oxide should be given because nitric oxide it is the strong analgesic drug. Okay, so you can use either opioid and nitric oxide along with the thiopental. Otherwise, the patient may struggle. He may shout. He may show the reflex change in the BP and the respiration. So to avoid that, to compensate poor analgesic action of the thiopental, you can add opioid or better to add the nitric oxide because nitric oxide it is the general anesthetics also. Okay, so you can add it as to maintain the anesthesia. Another important issue is that on cardiovascular system, sometime at very high dose it may produces cardiovascular collapse. That is very dangerous and it may produce due to the hypovolemia and shock or the sepsis. So these are the consequences of that. What is hypovolemia? When blood volume it is reduced suddenly, right? And when blood volume it is reduces, blood pressure will drop and there will be circulatory collapse. And due to that, patient suffer from shock. There is no blood supply to the different organs, and he may also suffer from the sepsis. Okay, so this may occur with the thiopental. So that is the disadvantage. Let's say quickly about its uses. So it is commonly used as an inducing agent. It can be also employed as a sole anesthetics, means single anesthetics without maintenance or inhalation anesthetics, especially in case of short-term operation that are not painful. So, for example, in case of the short-term surgery of your bone or very short surgery like someone fall down and there is injury where you just need to give the stitches. So in such small surgery, you can use it as a sole agent because it having a long T-half. So the effect it is persist for longer period of time. And let's see what are the other adverse effects. The other adverse effects are the laryngospasm, produces the contraction of the larynx, and it produces the respiratory secretion and irritation. So now since it produces the laryngospasm, it produces respiratory secretion and irritation, you need to give pre-medication. So pre-anesthetic medication need to be used, and we have seen in case of respiratory secretion and irritation that was there in the ether. So we can use the atropine. Okay, so it can be prevented by the atropine pre-medication and by administration of the succinylcholine. Why you are using succinylcholine? Succinylcholine it produces the relaxation of the muscle, so it can avoid laryngospasm or contraction of the larynx. Okay, so you can use atropine as a pre-medication and you can administer succinylcholine immediately after thiopental injection. Now let's see what are the logic or logistic behind injection of the thiopental and succinylcholine. So although you need to give the injection of the succinylcholine after thiopental injection to avoid laryngospasm, but do remember that don't do mistake and give thiopental and succinylcholine in the same syringe. Why it should not be given in the same syringe? Because both of them they react chemically. So that is the reason first you give injection of the thiopental and then after some time you can give the injection of the succinylcholine to avoid the laryngospasm. Next problem produces are the shivering and delirium. So it may also happen, it may occur during recovery as well. So that is not ideal property of the general anesthetics and produces the pain in post-operative period. So you need to give adequate analgesia and this analgesia should be maintained even after the surgery. So the post-operative, because once the recovery start, the patient may start suffering from the very severe pain due to, you need to give adequate analgesic drug. Next, it produces precipitate acute intermittent porphyria. So although we'll see this in detail in next lecture, but at this time you remember that the porphyria, it is one of the condition where there is hyperpigmentation. We'll see in next lecture in detail about this condition. Okay, so since it precipitate acute intermittent porphyria in susceptible individuals, once you identify those individual, then in those individual thiopental it is contraindicated. Okay, so based on the history you can decide whether injection of thiopental it is given or not. Let's see what are the other uses. Other uses of thiopental including rapid control of the convulsion. So it is anti-convulsant drug. It is also used to facilitate verbal communication in psychiatric patient. In psychiatric patient, they are suffering from the slurred speech. Okay, so to avoid that slurred speech and to facilitate verbal communication, you can use thiopental. Third important use is that it is one of the drug which is used for the narcoanalysis for the criminals. So narcoanalysis, later on you can just Google it out and see what it means, but you do see, remember that it is used in case of the criminal in order to know the truth behind the crime. Okay, so that is the use of the thiopentals. I have done with today's session. I have referred KD Tripathi Essential of Medical Pharmacology 6th edition for this topic. So I must thank the author of these textbooks for providing wonderful content on this chapter. So shortly I will be releasing question and answer links. So meanwhile, I thank you very much for watching my session. If you like my session, then do remember to give me a thumbs up, and for more such learning, subscribe to my channel. So just a minute, I will be releasing this attendance link in a chat box. So you should quickly give the attendance. Do remember that I have noticed some of the students are giving attendance very late. That is not acceptable. I am keeping this attendance link active only for 20 minutes. Okay. So yesterday I kept for 10 minutes, but I have received later on many requests. So once again I have activated. So today I am keeping it active for 20 minutes. So I have released attendance link. I hope you can see it. Quickly you can give the attendance and the quiz, because this is not just attendance, the quiz, it is also quiz questions are also being given in the attendance.